Welcome, and thank you for joining us today for a webinar on the overlapping impact of pelvic pain and GI disorders in endometriosis. I am Dr. Arvina Ninye, Chief Science Officer for the Society for Women's Health Research. SWHR is a national nonprofit dedicated to advancing women's health through science, policy, and education, while promoting research on sex differences to optimize women's health. We are delighted to have two distinguished speakers joining us for today's program. Dr. Jessica Shim, pediatric and adolescent gynecologist at Boston Children's Hospital, and Dr. Soni Singh, faculty of medicine and professor and chair of the Department of Obstetrics, Gynecology, and Newborn Care at University of Ottawa and the Ottawa Hospital. I would like to thank the sponsor of today's event, Sumitomo Pharma. SWHR maintains independence and editorial control over our program development, content, and work products. And as always, we will be live tweeting throughout this event and invite you to use the hashtag SWHR Talks Endometriosis on all social media. Endometriosis is a chronic gynecological condition that occurs when tissue that resembles the uterine lining grows outside of the uterus, forming lesions on other organs throughout the body and causing pain, often in the pelvis or back, between periods, and with intercourse. Approximately 1 in 10 women have endometriosis from adolescence through menopause, and for many, it can cause severe impacts to their quality of life. Endometriosis can go undiagnosed, misdiagnosed, and inadequately treated for years due to dismissing symptoms and societal stigmas surrounding menstruation and gynecologic health. Its co-occurrence with other conditions such as uterine fibroids, adenomyosis, and GI disorders can also contribute to the misdiagnosis of endometriosis. Today, we have two experts who will dive into the overlap of symptoms and disease between endo and the gastrointestinal tract. For example, women with endometriosis have a threefold increased risk of developing irritable bowel syndrome, particularly adolescents and young women. A study has also shown that women diagnosed with endometriosis, especially before the age of 25, are twice as likely to have Crohn's disease compared to the general population. Following presentations from our speakers, I will moderate a panel discussion and invite those of you who are tuning in live, to use the Q&A function to submit questions throughout the event. We will try to address as many questions as we can during the program, focusing on submissions that cover recurring themes or questions with broader applicability to the audience. So at this time, we will start with Dr. Jessica Shim, if you can turn on your camera, and she will be giving us an overview of endometriosis in young women. Thank you for joining us.
All right. Hi, everyone. Again, my name is Jess Shim, and thank you so much for having me today to discuss the overlapping impact of pelvic pain and GI disorders and endometriosis, and specifically when it may impact young women. My only financial disclosure is that I receive royalties from UpToDate. Here are my objectives. I'm hoping that after the next bit of time, we can review the diagnosis, prevalence, the potential impact of endometriosis, describe common signs and symptoms of endometriosis in adolescents and adults, cite common comorbid conditions, including GI etiologies among adolescents and young adults affected by endometriosis, and then briefly discuss the approach to diagnosing and managing endometriosis. This is a short overview, will obviously not be exhaustive of all the potential presentations or the potential treatments of endometriosis. And I look forward to hearing my colleague, Dr. Singh, also dive more into his work and the overlapping impact. One pause right here. I want to note that endometriosis can affect all populations assigned female sex at birth. While I will be using the terms female and women today, I do want to acknowledge that it can also affect transgender, non-binary, and gender diverse individuals, including adolescents. So briefly, the diagnosis of endometriosis is a chronic inflammatory disease defined as a presence of endometrial-like tissue outside the uterus that can respond to hormones and present as lesions, plaques, cysts, or nodules, and be located superficially along the peritoneum, deep and infiltrating, ovarian, or extrapelvic, and land in other locations such as the diaphragm. Classically, the diagnosis of endometriosis is through a procedure called laparoscopy. though we could also consider a clinical diagnosis of endometriosis after a thorough history, evaluation with exam and imaging, which could potentially help in minimizing diagnostic delay and expedite treatment. The World Health Organization cites that around 10% of reproductive age women and women and girls are globally affected by endometriosis. And I want to emphasize here that the prevalence of endometriosis in adolescents can be high. In one systematic review, they found the prevalence of laparoscopically confirmed endometriosis in approximately 62% of adolescents undergoing a diagnostic laparoscopy, 70% of adolescents with dysmenorrhea or painful periods, and in 75% with chronic pelvic pain resistant to treatment. More importantly, many adults with endometriosis also report their symptoms starting in adolescence, with one registry survey study citing that 2/3 of adults reported their first symptoms starting before age 20, and around 1 in 5 had pain before age 15. The reason why we are talking about endometriosis today is the profound impact that the disease can have. And I want to quickly emphasize here the impact of the disease on multiple aspects of women's lives and across the lifespan. I have the privilege of presenting work here that my colleague, Dr. Singh, was a co-author for. And this figure here is provided to really illustrate the theoretical effects of endometriosis across a life course, particularly if left untreated. The orange line demonstrates the worst case scenario of an individual who begins to experience untreated and symptomatic endometriosis from adolescence. I really appreciate this graph because I capture my patients in childhood and adolescence, and this is the point in time where I really want to intervene and provide a diagnosis and management. This time point is a developmental stage for personality, social development, life planning, and that can really be influenced by the disease and then have downstream effects once the individual becomes an adult and is trying to have a successful career or establish relationships and build a family, etc. So firstly, let's briefly go over the symptoms. Many of us are aware of the symptoms of endometriosis, including pelvic pain, dysmenorrhea, dyspareunia or pain with sex, cyclic dysuria or dyschezia, infertility, and then symptoms of endometriosis may not even occur at all and be incidentally identified. We know that the symptoms in adolescents may vary from those in adults. In one study that compared symptoms in adolescence versus adulthood, the study found that more adolescents recall early onset dysmenorrhea and had more nausea accompanying their pain. Additionally, adolescents may have symptoms outside of just dysmenorrhea or painful periods, and they may also have severe acyclic pain, with one recent study reporting acyclic pain in approximately 70% of the cohort at baseline. In a table on the right, we can see that the authors kind of looked at subjects with and without endometriosis and found that the most common presentation of pelvic pain in adolescents was actually both acyclic and cyclic pelvic pain. Acyclic pelvic pain was present in over 90% of the adolescents. Outside of these pelvic pain symptoms, we also know that GI symptoms can be quite common. In this one cohort study, they looked at a variety of GI symptoms, including diarrhea, constipation, nausea, vomiting, rectal bleeding, and bloating. And 90% of women with endometriosis had GI symptoms, with bloating being the most common. All GI symptoms were similarly predictive of histologically confirmed endometriosis, and the authors noted that bowel lesions were actually present in only 7.6% of this cohort. So the author's takeaway here was the astounding high rate of GI symptoms in women with endometriosis, despite very few having actual bowel endometriosis. In another study that came out of Sweden, they assessed GI symptoms in patients and controls, and compared to controls, patients with endometriosis experienced significantly worse abdominal pain, constipation, bloating and flatulence, defecation, urgency, sensation of incomplete evacuation, and greater influence of intestinal symptoms in daily life. More severe nausea and vomiting was identified in patients with lesions within the bowel or in close proximity, but there really was a poor association between symptoms and with the other symptoms and lesion localization found. Now I'd like to briefly talk about the signs of endometriosis that might potentially differ with adults and adolescents. Firstly, signs on a pelvic exam might quite vary or be limited, particularly in teenagers who cannot undergo a pelvic exam, whereas in adults, if an adequate pelvic exam is performed, one might appreciate deep infiltrating nodules or an endometrioma, for example. Signs of endometriosis may also vary on imaging. With adults, if a transvaginal probe is performed or an MRI might pick up on deep infiltrating disease and assist with surgical planning. Whereas again, imaging might be limited in our adolescent patients. Imaging may also be normal in adolescent patients or adults who have evidence of superficial peritoneal lesions. And some of this variation here can be appreciated in this recent study that I've put here just to highlight the differences in how endometriosis may appear across the lifespan. In this study, the authors noted a significantly higher prevalence of isolated superficial lesions among young adults compared to other adults. And conversely, deep infiltrating lesions were more frequent in women 24 years and older compared to those 24 years or younger. And this trend remained consistent further into adulthood. Now I would like to briefly talk about the association of endometriosis. And so firstly, I'd like to emphasize that there is an association between endometriosis and other pain syndromes that can be identified even in our adolescent patients. Studies have found a higher prevalence of migraines and IBS among adolescents with endometriosis compared to their unaffected peers. And in one cohort study, they found that over half of adolescents had a comorbid pain syndrome such as IBS, interstitial cystitis, chronic headaches, low back pain, vulvodynia, fibromyalgia, TMJ, or chronic fatigue syndrome. Looking more closely at these comorbid relationships, we can look closely at the comorbid relationships between endo and GI disorders. And this is just a table from a study that investigated 188,000 women in the UK Biobank that was used to validate the co-occurrence of endometriosis and GI disorders, where the authors looked at relationships between endometriosis and IBS, GERD, peptic ulcer disease, and combined GERD and peptic ulcer disease phenotype in IBD. In this table, the first row, they evaluated if women with endometriosis were more likely to have a diagnosis of a GI disorder. And in the bottom row, authors investigated the reverse direction, where women with GI disorders were more likely to have a diagnosis with endometriosis. And of all the relationships, there was the strongest relationship between endometriosis and IBS. So women with endometriosis were 2 times more likely to be diagnosed with IBS, and women with IBS were around 2 times more likely to be diagnosed with endometriosis. And again, this relationship between endometriosis and IBS has been closely identified and established. In a systematic review and meta-analysis, the authors found the incidence of IBS in women with a previous diagnosis of endometriosis about 2-fold greater risk. And the overall odds ratio of a history of IBS in women with endometriosis was around 3.1. This relationship has been more closely explored in a study that came out of Boston Children's, where they looked at adolescents with endometriosis and their risk of IBS. And the odds of IBS was 5.26-fold higher among adolescents with endometriosis than without. And in girls with severe acyclic pelvic pain, the odds of IBS was 35.7-fold higher in girls without endometriosis and 12-fold higher in girls with endometriosis. Next, we can also think about the immunologic alterations in endometriosis and the possible associations between endometriosis and autoimmune diseases. So, in a systematic review, there was an exploration of the association between endometriosis and several autoimmune diseases, including lupus, Sjogren's syndrome, rheumatoid arthritis, autoimmune thyroid disorders, celiac disease, multiple sclerosis, IBD, and Addison's disease. There were few high quality or well-designed studies with large sample sizes to substantiate this, but I did want to point out that, there's been a lot of other ongoing research in the investigation between endometriosis and IBD, for example. In one study using the Danish registry, they found an increased risk of IBD even after 20 years after a diagnosis of endometriosis. So now that I've hopefully done some justice to, describing the overlap of symptoms of endometriosis with other conditions and the association of endometriosis with possible GI conditions, I'd like for us to think about maybe perhaps the best way to diagnosing and treating other conditions. I think firstly, while clinicians can have a high suspicion of endometriosis, there should also be consideration of these other potential diagnoses, and clinicians should consider evaluation or referrals for other potential processes. I really like this table here from the manuscript advocating for a clinical diagnosis of endometriosis, which provides an algorithm with the symptoms, history, exam, or imaging that may suggest alternative diagnoses outside of endometriosis. For example, the authors list here that symptoms of severe non-cyclic constipation or diarrhea may suggest IBS. As far as the treatment of endometriosis, we know there are a lot of components, and a multimodal approach can often benefit patients with endometriosis and chronic pain. So these include medical management, surgery, complementary and lifestyle modifications. And highlighting here that it's not just a multimodal approach, but also an interdisciplinary approach as well to our endometriosis patients. For me, many of my patients are referred to GI for evaluation and management for possible other underlying GI disorders. We have a collaborative relationship, and often we coordinate doing procedures where I might do laparoscopy, and our GI specialists may perform their endoscopy or colonoscopy under the same anesthesia. And then our patients may also benefit from seeing pain specialists, acupuncturists, physical therapists, just again highlighting here a multimodal approach, an interdisciplinary approach for the variety of symptoms that our patients with endometriosis might experience. And then lastly, for future direction and impact on our patients, we know that this just doesn't take clinicians or people in women's health space to recognize endometriosis and the overlap, but it also takes others, such as our GI clinicians themselves, to recognize the possibility of existing endometriosis. I really liked this figure from a primer for GI physicians, kind of a little diagnostic algorithm or tool for GI clinicians to really recognize the symptoms and when a referral to gynecology may be indicated. So in conclusion, I know that was brief, but hopefully I was able to highlight that endometriosis is a highly prevalent condition that can cause significant symptoms, including GI symptoms in both adolescents and adults. Endometriosis is often associated with other conditions, including GI conditions, and increased provider awareness and screening for endometriosis and these GI conditions is sorely needed to improve our patient outcomes. Thank you all for allowing me to speak today.
Thank you so much, Dr. Shim. That was a great presentation to open up this topic of endo and these symptoms and GI disorders. And so now I would like to introduce Dr. Soni Singh to discuss the processes for diagnosing and treating endo and shine some light on how women can navigate these options with their for their personalized care plan.
I'm just checking. Can you hear me okay?
Yes, we can, and we can see
Great.
yourself.
Thank you. First of all, thank you for inviting me to join this wonderful panel. And Dr. Shim is such a wonderful speaker. I can certainly see how in the clinical setting, you have a very calming voice and a very kind way to approach this very complex problem. I come to you from the unceded territory of the Algonquin and Anishinaabe people in Ottawa, Ontario, Canada. And again, thank you so much for having me. My goal is going to be to further focus on the GI aspect of our practice in endometriosis, and hopefully that will help the discussion as we move ahead. Here are my disclosures, and we are involved in clinical trials and therapeutics as we go forward in our program here in Ottawa. My objectives are to explore the relationship between endometriosis and bowel dysfunction, to identify some gut-related issues amongst patients with endometriosis, to understand the disease burden and the impact on the individual. And I would like to leave you with some tips. Now, I've looked at the participant list and I see some incredible scientists and some wonderful patient advocates who have really talked about these issues well before we even had an understanding of the overlapping pain syndromes and the relationship of the GI system and endometriosis. But before we begin, I just want to remind everybody that the gastrointestinal system for many is truly a pain. However, we need it to survive. Yeah, we don't probably give it enough attention to understand that really it's how we exist. We extract nutrients from the food we eat. It includes energy and getting the hydration that is necessary. And so we need the stomach, we need the small bowel, the large bowel, the liver, the gallbladder to keep us going and to exist. However, when things don't go well, there are other symptoms that develop because of many different reasons we're going to get into. But essentially, excess gas, abdominal, or some may call it belly pain. If things get backed up, it's constipation. If things move too quickly, it's diarrhea. Pain on defecation is slightly different than the abdominal pain. For those who struggle or have patients who have had this, you know exactly what we're talking about. And of course, the most dangerous situation when it comes to bowel issues are blockage or an obstruction, which can also lead to a perforation. So again, that last line isn't very common, but in case people are worried, there are some red flags that we use to decide on when to intervene or when to get involved. So if somebody has those symptoms, plus has a fever, has rectal bleeding, has severe and sudden pain, has sudden change in bowel habits, nausea and vomiting, jaundice, or unintentional weight loss, they need to seek immediate medical attention. The other time to be worried is if we have GI symptoms plus a family history of cancer, inflammatory bowel disease, which is ulcerative colitis or Crohn's disease, or celiac disease. And again, in my own family, we've been impacted by colorectal cancer. So again, any rectal bleeding, any signs or history that needs regular monitoring is beyond the scope of today's discussion, but please get it checked out. It is treatable, it is manageable, and so we want people to be aware of that as well. Irrespective of endometriosis, everybody online is still a human and is still at risk of all sorts of things that can impact anyone. Now, when I think of gastrointestinal issues, I do think about things in structural form. They could be benign or cancer. We're not going to talk about cancer today. Or they could be functional, or what is being increasingly called the gut-brain disorders, where the things may be related to things not moving in the way they should, the actual organs being more sensitive to pain, the actual alteration of the bacteria that live along our lining. We have such important relationship with the bacteria that line our gut, and sensitivities, mainly to food. And again, I think these are very, very common issues. But one quick moment on the structural things. So there is, of course, endometriosis, which may actually physically impact the bowel, or even through an inflammatory method. Pelvic masses, uterine fibroids are all things that can lean on top of the bowel and cause problems. But one of the things we forget, because surgery is often a treatment for those things above, surgery can also be a source of problems in the form of adhesions. And so I think when you hear some of us talk about using surgery in a very careful manner, it's because we don't want to see complications from surgeries that may relate to situations later on, such as bowel obstruction. And endometriosis is not just one disease. I think many of you already know that. Superficial disease is one type of disease that Dr. Shim had talked about. Ovarian endometriomas is another form. But the area that I focus on where the disease does invade the bowel or impacts the bowel is called deep endometriosis. And not every patient has every form, but really important for us to distinguish that there are different forms. Now, when do I consider endometriosis being involved in the gut? Well, again, I'm a gynecologist, so I always think about it. But for everyone else, I think we want to think about it when symptoms get worse with the menstrual period or just before the period. Now, all bowel conditions are also responsive to the hormonal changes in the cycle because the bowel has receptors of estrogen and progesterone, just like our reproductive organs would. Endobelly is something we hear a lot about. We can certainly talk about that in chat, which is a bloating sensation that can be quite extreme, not directly related to obstruction, rectal bleeding with the menses, or if someone has infertility and pain. And just remember, this is something that we're very passionate about, is that routine transvaginal ultrasound misses the diagnosis of endometriosis. And this is our own work in 75% of patients. So if they have a scan just done routinely in the community, we may miss obvious disease. But expert ultrasound and MRI, again, has to be read by people with experience, can diagnose bowel endometriosis. So using something called soft markers, where we look for how the organs slide against each other, or if we actually see nodules. And I want to show you something that we had named here in Ottawa, simply because we didn't like the other term used by our European colleagues for this sign, was called the moose antler sign. So once we see this type of sign, we know there's a bowel lesion invading the muscle of the bowel. And that may be new to some of you, but we need to improve the ability with imaging to diagnose these things, because even surgery can miss the diagnosis in inexperienced hands. So I wanted to touch about a little bit on endometriosis, and talked about the medical and surgical options in the first presentation as options. But I would like to spend most of my time talking about what we call the gut-brain interactions of the bowel. And I think this is so important. And in fact, as we were promoting this webinar, I saw some folks even bring this up in their feedback. And that includes that the gut really can be controlled by the brain, but the brain controls everything that we do. And not only is there the physical proximity to the uterus, the bladder, and the bowel, but all of that area is controlled by the same nervous system, the same central computer. So remember, any social stresses, and I'll tell you, I have experienced all of this. You have anxiety, you have depression, major life events, you lose a loved one, you have issues with accessing bathrooms, or you have difficulty with a significant history of trauma, whether it be medical trauma, physical or sexual violence, social support and coping. All of those things are underlying some exacerbation of what people may experience, and we can't ignore those triggers that may be worsening that gut-brain interaction. However, having said that, that is the volume of some of the experience that people may have. But when we have a gastrointestinal system that is sensitized through infection, things aren't moving as well. There's a change in the bacteria or the microbiome because we took antibiotics for something, or there's a disconnection because of a nervous system disorder such as multiple sclerosis, then we are in trouble. And those other factors don't let us cope in the same way. So someone who has no stress and is doing well may end up having all those changes in their gut or a medical issue, but may not feel it the same way as someone who is under a lot of stress. I know that sleep and being burnt out is impacting many of us, and that may worsen some of our symptoms. Finally, there's a neurologic aspect where some of the tissue And I'm trying to use words that may be a little bit more simple, so I apologize to our scientists as well. But basically, the bowel in some cases can be hypersensitive in that if it gets distended because one is constipated, in one patient, they may not feel anything. In others, even a bit of distension may trigger a lot of pain. The menses or having a period may trigger pain as well. And so all of those things need to be taken into consideration when we try to balance it. So let me try to present it in a slightly different way. So think about the fact that, everybody comes through life, everything is going well, and there is no pain, but there's a stressor. You lose a family member. I know that when we lost a family member to colorectal cancer, it really significantly impacted us as a family. And it really made us worry about what our own situation was going to be or what our other loved ones' risk was going to be. So there's a whole level of stress and anxiety that may be developed, or maybe your job. Maybe you don't like your job. Maybe it's some illness. Maybe it's the world situation or politics. But there is underlying stressors that may impact an individual. And then you get that hit of the infection, the antibiotics that you were given for some other condition, or there was an underlying risk of a neurological issue. And so two things happen after you get that hit. You either recover, right? So things get better. My life got better. The stress came down. My gut recovers. The bacteria are doing a good job. I'm eating healthier. I've eliminated things that may make my gut worse, or they continue because life didn't get worse. I'm really worried about the world situation. I'm really worried about my children or my own life, whether I'm going to have kids. So there's so many scenarios that I see patients walking through. And again, understanding that they may need help. And then what happens is you go through testing and you go through visits, and often, just like endometriosis, things are delayed. The care to access these things may be delayed, and people continue to struggle for months to years. Finally, you do get that visit and you get investigated, and hopefully you find that right therapeutic relationship that allows one to get the right support and counseling and treatment. But to undo some of that takes time and it takes some work. So here's a great article from the Mayo Clinic Proceedings that goes over what physicians would be recommended to help their patients with, or any healthcare provider. So first of all, exclude causes of the patient's symptom. Do they have inflammatory bowel disease? Is there some sort of infection? Is there something underlying? And number two is develop a trust and therapeutic relationship. Often patients who've had gut issues are dismissed, are told it's all in their head, and then they're discharged. And I see that so often. And I think it's important to develop the relationship to say, you know what, look, we've got lots of options, and this is what we think we should move with next. And if it doesn't get better, let's go back and review. Education is another component that comes up as a recommendation. So how does the gut work? How does the bowel work? What are we going to focus on to improve that function and quality of life? So make clear goals and establish a treatment plan, which might include medications or non-pharmacological modalities as well. So what your visit might look like when you think about all the stuff you're going through is that you may end up having you go through your medical history, your physical exam, looking at your blood work and imaging to make that diagnosis. Now, my time is running out, so I'm just going to hit on a couple of key points for what it means to move forward. But my message is chronic gut issues and endometriosis do take time to heal and need long-term support and care. So we do have an approach here in Ottawa that looks at approaching how we look at all of pelvic pain. And so we have lots and lots of options. I don't want anybody to ever feel they don't have options. But in summary, in my last couple of slides, is simply that education is the key. And that may include dietary changes. It may be as simple as avoiding triggers like alcohol, caffeine, fried food, stress, and finding the right support and help as well that may make life better. One public service announcement is that we often say fiber is what we want to go with. It's not always the right answer, believe it or not, and it's something you might find quite interesting. But there's a big difference between bran, which is insoluble, versus soluble fiber like psyllium. So do your research, and often psyllium or soluble fiber is what you need to help with that severe constipation that might interrupt the gut. And so constipation is something that I see in so many patients, especially our young patients, as Dr. Shim would probably attest to as well. And so we want to do the right thing for them as well. And don't forget that the pelvic floor is made up of a lot of muscles. And I would be remiss if I didn't go over the fact that we do want to acknowledge that pelvic floor physiotherapy is often an important component in healing or working with gut issues. And I think we can't do all of that without understanding that the pelvic floor is a component of our care. Here are some of the resources I'll leave with you, and I can certainly share them online afterwards. I do like badgut.org or the International Urogynecology Association site, yourpelvicfloor.org. And probably my favorite resource for those who want to explore the FODMAP diet is from Australia at the Monash University. So thank you so much for allowing me to participate, and I look forward to any comments you may have. There you go.
I invite Dr. Shim, if you want to turn your camera on. This has been, two amazing presentations and setting a good stage for our Q&A portion of this webinar. Again, we invite attendees that are tuning in live to submit questions using the Q&A function. Within the app, we will try to address as many individual questions and common themes as we can during this segment. Please note that our conversation today is intended for educational purposes and is not intended or implied to serve as a substitute for medical, professional, or legal advice. We encourage all patients and caregivers to confirm information and consult their healthcare providers to determine individual needs. So I'd like to start with the question to get this conversation going. And we've talked about the gut, we've talked about endo, and the approach to treatment sometimes can be surgical, medical, there's a combination. How do we separate the treatment for endo and gut health? Like what, because if you treat, you have surgery options, for example, for endo, will that alleviate the pain? What is someone to expect when they're going about addressing both of these issues? And maybe Dr. Singh, you can start off.
No, it's a great question. And I think I would want to take a step back and acknowledge that every patient who comes in the ideal world would not just be counseled about endometriosis, if that's what they're coming after, but just general health. And I think we miss that a lot. So I think understanding bowel health, understanding how the system works is critical. And so the way in which I look at it is back to that paper that I was talking to you about, where you want to exclude some things that you can treat that are obvious. So if somebody's got obvious organic issues like inflammatory bowel disease, or does have deep endometriosis that is invading into the bowel, then I do need to deal with that. But at the same time, I'm counseling patients on, how to manage a better diet if they're constipated, how to work on reducing things that might make the inflammation worse or the pain worse. So my answer would simply be that you need to work on everything together, but you do need to figure out what are the triggers. And what we talk about is there are certain pain generators that you must manage, like endometriosis, adenomyosis, or fibroids, and at the same time working on the gut at the same time. Dr. Shim?
Yeah, I think the other part of the question, just talking about treatments and their success, I just feel like unfortunately we don't have a lot of like good high quality data to suggest that one specific type of surgery or removing the lesions will then definitely guarantee improvement or resolution in pain, let alone quality of life outcomes or even some of these bowel associated symptoms. So I think this also speaks to Dr. Singh's point of really addressing kind of in a variety of ways for patients, just because we unfortunately do need more research to determine kind of the success and the efficacy of different treatment modalities. And also because we know that there is a potential for recurrence of pain symptoms or recurrence of disease.
And I wanted to touch on this in Dr. Singh, you mentioned it towards the end, and I know whenever you're dealing with chronic health conditions, we see constantly individuals are asking about diet and nutrition. And there's the anti-inflammatory diet and the Mediterranean diet. And if you go paleo or vegan and all these different areas, as you know, as many women with endo and conditions, of course, if they have IBS or, Crohn's and all of that, are considering finding ways to manage their symptoms through their diet. Are there any leads or what advice can you share to help them explore this approach? I know there's no particular diet, but like what should they be thinking about? What should they be considering? Who should they be consulting?
I think, yeah, people always ask me about which diet is perfect. It's what's right for you. And I think that really making a personalized plan for endometriosis, for many of the gut issues, every plan will be different. And I think we have to be careful to generalize that there's one answer for everyone. So what we encourage our patients to do in our clinic is to look at, first of all, just what are the triggers? So easy stuff to take out, not easy because it sounds easy, but alcohol, caffeine, chocolate, and citrus foods were something that we used to use for bladder dysfunction, but can also irritate the gut as well. So we ask that patients consider eliminating those things. A lot of people are lactose intolerant, and so once they've made those changes to their diet, they may see an improvement. And going into a diet like the FODMAP or the anti-inflammatory Mediterranean diet is just a plan to be followed that might work for you. So our general plan is to do something and try your best, but also be kind to yourself because none of us have been able to maintain a regular diet, even exercise regimen, and that's okay. And you will have good days and bad days. But once you find that right fit of what you can avoid and what you should take in, things will get better.
And Dr. Shim, did you have anything okay.
No, I echo everything Dr. Singh has said. I agree with that. And I was just smiling to myself, thinking of I had a recent patient who went off to college and had found the college diet, the foods kind of flared up their symptoms. And then they came back to me saying, you know what? I started going grocery shopping and incorporating more fruits and eating more things off campus. And they had really found that that actually helped improve some of their symptoms. And so I really echo what Dr. Singh had to say.
And actually, to that extent, I think that's it's very important because sometimes that access is a challenge, and you might have you're on campus and you have this dining hall with buffet options through and through, or you might be living off campus, or you live in a community where you might not have the access to try out these different things. But what I'm hearing is essentially making sure that you're testing, and I'm assuming in smaller doses, figuring out what works and paying attention and really learning your body and paying enough attention to your body, what goes in, what comes out, and how it affects you. And so, are there, there are documented disparities that we know in symptom severity, disease onset, and prevalence among different groups of women concerning gynecologic health and GI health. What are some special considerations that you'd like to highlight for maybe a particular subpopulation? It might be for ethnic population or geographic or age for women with endometriosis. What should they be thinking about, or how should they, how can they better navigate their care?
Do you want to go first, Dr. Shim?
I think in the context of, I can speak for my perspective in managing adolescents, for example. I think we know that there can be a lot of disparities in access to care. And I think a lot of that can be um, for a variety of reasons. I think there are also stigma or community perceptions of endometriosis and symptoms. I think it could also be provider mediated or like from my perspective, pediatricians acknowledging or being aware that there is endometriosis that can affect adolescents. And I think several studies have also found, adolescents and their peers, in their discussion or like normalization of menstrual symptoms or pain symptoms. So I think the first thing I just want to emphasize is just the need for further education that is spread in the community to kind of improve access and improve recognition of symptoms so that that can hopefully mediate some of the diagnostic delay that we see.
Yeah, no, I have a huge interest in this area. And we've published quite a bit on race and ethnicity. And so I'll go beyond the adolescent population because that is wonderful information. I'm glad we have experts like yourself, Dr. Shim. But in terms of understanding that we are trying to repair hundreds of years of damage towards the approach to women's health, and especially even the racism and sexism that continues even today. So, for example, we do know that some of the worst endometriosis in terms of disease phenotype presentation, combined with other overlapping syndromes, happen in specific ethnic or racial populations. So in Canada, we had a study from my colleagues in Vancouver where we are both have a high, multi-ethnic population. Asian women actually had some of the highest disease burden compared to their non-Asian counterparts. We know Black women have fibroids and endometriosis, so you can never talk about one without talking about the other. And then adenomyosis, which is the third, evil triplet, I guess, of this whole scenario, is dismissed often and only now coming to the forefront because imaging and further diagnosis is being made. And so I think that we do have to understand that different populations will biologically are more prone to certain conditions. And then the environment. We know that women in stressful situations are going to struggle even more. How do you get access to care when you don't feel safe at home? You may be significantly bleeding and pain. Last thing you're worrying about is trying to get care. Meanwhile, the disease or situations may progress. And so those are the patients I worry about the most. And in Canada and in the US, we have our Indigenous population who haven't even been studied, let alone, helped in this access to care. So bottom line is you're absolutely right. We need to understand each patient has a personal story and unravel their situation so that you can help them individualize that plan.
That's actually a great cue up to, I wanted us to transition a bit. Last year, SWHR convened an expert working group to address challenges in diagnosing and treating endometriosis. For those tuning online, Dr. Shim and Dr. Singh were on this working group. And one of the resources we launched were some videos to help healthcare providers better recognize endometriosis in their patient population, as well as to increase general awareness about the patient experience. And so we are continuing the journey to wellness with endo with additional perspectives shared by endo patients and advocates. In today's audience, we'll get to be the first to view Soyini's story. And so in this video, Soyini shares her personal experiences as an endometriosis patient and a healthcare provider and discusses the importance of shared decision-making. So I see we're queued up, so let's go ahead and watch that now.
Hello, my name is Dr. Soyini Hawkins. I'm a minimally invasive gynecological surgeon just out of the suburbs of Atlanta, Georgia. I take care of patients at the Fibroid and Pelvic Wellness Center of Georgia, and I am also an endometriosis patient. The medical side of me would, of course, tell you it has an incidence of 10%, right, of women that are in their reproductive age. But the patient side of me would say that it can impact every facet of a woman's life. It can impact their significant other, it can impact their children, it can impact their social circle of friends and family. It definitely is a disease process that's well beyond that 10%. So a lot of patients typically find out when nothing else makes sense. I was missed in my diagnosis because I had fibroids first. Fibroids are growths of the tumor. They were very easily seen on ultrasound. But even though I was going for my annual exams every year, I was never told I had an enlarged uterus. It wasn't until I started to have pain, which is the hallmark of endometriosis, and immediately my pain was attributed to my fibroids. I had surgery for it, and it was during my surgery that I actually got diagnosed with stage 4 endometriosis. So there are a lot of conditions that get mixed up in the diagnosis of endometriosis and will delay it. Some of the more prevalent ones are irritable bowel syndrome, PCOS, even though the hallmark of that is not necessarily pain. Some patients will get diagnosed with pelvic inflammatory disease. Some patients will be told that their fibroids are what's causing their pain, and I call fibroids a sister friend to endometriosis sometimes. And what we have to realize and recognize is these can all live concurrently. They can all live together. Patients need to know that shared decision-making is a thing. Shared decision-making means that you're having discussion, and it's a communal discussion of understanding and planning, and that your actual goals are taken into consideration in every move that you make with your doctor. No, you shouldn't have a medical degree and a deep clinical understanding of all of the nuances of the disease. However, in shared decision-making, that means that your doctor should at least be giving you a deep understanding of what's going on with your body. You should understand what your options are. You should understand the risk and the benefits and the alternative to those options are. You should understand that it is always appropriate if you feel like it's necessary to get a second opinion, because if your provider wants the best for you, even if the best for you is not them, they'll be happy for you to be getting taken care of. Shared decision-making is essential to our care as endometriosis warriors. The advice that I would give to someone that is new to this journey of endometriosis is advice that I did not get at the start of my journey, and it is that you are not alone. There is a community of women who can empathize with you, with what you're going through, can be a resource for options or even just a listening ear. The communities are vast. Find out locally what you can do to advocate for yourself or be guided in your advocacy for yourself, or maybe even give into communities that are similar to you. It was a very, very lonely journey for me pre-social media. And I think that if I would have had the community that's available to us now, I would have had some hope.
Welcome back. And so I would, as we, this was a bit of Soyini's story, and she comes from the perspective of a patient and a provider in this space. But as we take this into, she talked a lot about shared decision making and dealing with gut and endo care. How does a patient manage shared decision making, coordinating multiple providers in this space? And it's different health issues, but you want them to work together. How can we assist them? So Jessica, maybe you can start off, because I know you had mentioned, at least in the laparoscopic surgery, that you had some coordination there with some GI doctors.
And I think this was one of the things that I loved working with the working group, and we had created that toolkit for teenagers as well, is ensuring that providers know who to refer to in a timely fashion if there is a high suspicion for endometriosis, but also having these collaborative relationships, and knowing who to, like, for example, in my experience of pediatricians, knowing who and where they can refer to have specialists for endometriosis accessible. But Dr. Singh.
Yeah, no, I think the one thing we have to be honest about it is access is a problem. And I do feel that as gynecologists, in our system is a little bit different than the one in the US, but nevertheless, we should be the champions for these young girls and women and others we provide care for. And we do have to do the homework. We have to figure out who we're going to find to get the help that we need. But every women's health expert should have a basic understanding of endometriosis and gut health and bladder health, and be able to counsel or point people to the right resources. But I will be honest, I've had a really tough time finding GI doctors who focus on functional gastrointestinal issues. So just like gynecologists, there is need for more education about endometriosis amongst gynecologists and access to more and more folks who do more complex care. We need the same thing in gastroenterology. So just going to a gastroenterologist and getting a colonoscopy and being told everything is normal is probably very frustrating for the majority of patients, at least that I see. And these are continuing challenges that our patients have. So it's not all perfect, but we are working. I think Dr. Shim and I are both working to find that right team. And we work on it every day. Pelvic pain experts, naturopaths, even who I work with for dietary considerations, gastroenterologists, and many more people.
Well, thank you so much. And I did want to put a note because it came up in some of the questions, but also the research and the data that you both mentioned is lacking in certain areas. And SWHR always encourages the inclusion of women in clinical trials and research. And so I think that opportunity is there for certain studies and that we encourage individuals to participate so that we can get the data and have it available and understand what's going on in our patient populations. And so before we wrap up, I do have one last question. We have a diverse audience of patients and healthcare providers, researchers, industry, even policymakers that tune into our events. And I want to ask each of you, what is one takeaway that you would recommend to one of these viewer groups to help them support either research and or healthcare for women living with endometriosis? And so let's start with Jess, and then we will go to Sony.
Oh, I think that's a fantastic question. And I wish I was Dr. Singh, who had a little bit more time to think over his answer. But I think just again, highlighting the fact that we really need more research studies, kind of evaluating this further relationship. I saw several questions about kind of what are the underlying mechanisms even too. And I think that's great. I think there are many common pathophysiologic mechanisms between endometriosis or IBS, for example, inflammation. We also think about hypersensitivity. We also think about what are the common mechanisms between endometriosis and inflammatory bowel disease. I'd love to see more research there, kind of exploring the underlying genetic or other pathophysiologic mechanisms that could explain this high coexistence.
So I have quick ones for each group. So for patients, that are especially on the chat that are really struggling, your experience is real. It fills my day and it fills our wait times in Canada. And your struggle needs the support and help. And there is help out there. It's just finding it. So you have to continue to advocate for yourself. So that's my key tip there. For scientists, to really work with clinicians to understand what the real questions are. There's a lot of science that's going on that isn't connected with what the real question is, which is what the patient's goal is to get better down the road. And I think that is my tip to scientists. And finally, to policymakers, make it a priority. Make it an understanding that women's health truly has been ignored all these years. And these individuals who are struggling with pain, GI symptoms, and the fact that in our clinics, we're seeing all of them together, that we need to treat them together. And so it's not that we have an endometriosis expert, it's a fibroid expert or a bowel expert. It's how do you really set up systems that provide the holistic care, the one-stop shop that I would want for my own family member and loved one. So policymakers, it's up to you to fund programs like that and not the silos that we created. So there you go, one for each group. I did have more time.
Thank you so much, Dr. Shim and Dr. Singh, for your time, your insight, your transparency, and also thank you to Sumitomo Pharma for their support of this event and SWHR's endometriosis program. With contributions from our endometriosis working groups, SWHR has developed an endometriosis toolkit, a guide for teens, and some additional resources and materials for patients, healthcare providers, and policymakers that can all be found and downloaded from the Endometriosis Health Focus area page under our programs tab on our website, www.swhr.org. The Teen Toolkit is also available in Spanish. And so we will be sending out an email with a recording of today's webinar to all registrants, as well as post the recording on the event's webpage for future viewing. So please be on the lookout for that and feel free to share with others. And if you haven't already, sign up for our newsletter and connect with us on social media as we continue this important conversation with hashtag SWHR Talks Endometriosis. Thank you for joining us.